Dear listeners, I am Dr. Salma Hashmi. Today we are going to discuss a very important topic, and that is detection and management of intrauterine growth restriction. The role of color Doppler in detection of IUGR. How does it help? It helps in the detection of complications of pregnancy, detection and characterization of certain fetal abnormalities, detection and management of maternal disease. SGA stands for small for gestational age. Being SGA indicates merely that a fetus or neonate is below a defined reference range of size or weight for a small gestational age. Many SGA fetuses do not suffer from IUGR, but they are small because of perfectly normal genetic influences. Like pelvic bones will be different in a woman with less height, and they'll be different. Pelvic bones will be different in a woman who is long in height and she has a broad pelvis. IUGR indicates that a pathological process is operating, thus preventing the fetus from reaching its growth potential. Many IUGR fetuses are not small for gestational age. Example, a fetus with less support from mother, like in reduced blood supply from mother due to placental insufficiency, etc. They would be at a greater risk of complications of IUGR than most of small for gestational age fetuses. Now we should discuss the uteroplacental circulation. The uterine artery is a branch of anterior division of internal iliac artery and divides further into 4 arcuate arteries. Each arcuate artery divides into more than 25 spiral arteries. There are therefore between 100 and 200 spiral arteries which enter the intervillous space. From serosa of uterus, the arcuate arteries enter the myometrium and becomes radial artery. The radial artery divides in basal and hundreds of spiral arteries to enter the decidua, where it enters the intervillous space. Now the spiral artery invasion. During early pregnancy, trophoblast cells invade this space and disrupts the wall of spiral arteries as a part of the process of placental formation. Now there are waves of spiral artery invasion. In first wave, between implantation and 10th week, the trophoblastic invasion is limited to the decidual layer. In second week, from 14th week until 22 weeks, the invasion extends as far as the spiral arteries. The invasion of spiral arteries affects the resistance of blood flow within the spiral arteries and thereby the arcuates and the main uterine arteries. Now we'll discuss the technique of examination of uterine artery. The flow velocity waveforms are obtained from the lateral lower quadrants of the uterus, angling the transducer on either side of the uterus towards the cervix. Signals achieved in this way are assumed to be originating from the uterine arteries. It's important to angle the transducer to improve the angle of insonation whilst maintaining the vessel identification on color Doppler. This is now the external iliac artery, and its flow pattern is like this. And this is just above the external artery. The pulse Doppler gate on proximal uterine artery is just above the external iliac artery, and its waveform is like this. It's different from the external iliac artery waveform. Waveform analysis. There are 3 common methods of describing peak blood flow velocity waveforms. Number 1, the pulsatility index. Number 2, the resistance index. And number 3, the systolic diastolic ratio. Pulsatility index, or PI, most closely relates to the pulsatile flow in vessels with elastic properties. Decreased end-diastolic flow and consequently raised resistance indices above 0.58 is considered abnormal. A notch in early diastole in either uterine artery is abnormal, suggesting failure of trophoblastic invasion of spiral arteries. Waveform with high pulsatility and early diastolic notching. A uterine artery pulsatility index greater than 1.45 at 18 to 22 weeks is suggestive of uteroplacental vascular insufficiency and obviates the need to report the presence or absence of a notch. Let's discuss the significance of umbilical artery waveform studies. Normal uterine artery waveforms result in normal pregnancies, and abnormal waveforms are associated with pregnancy-induced hypertension and fetal growth restriction. A good diastolic flow and disappearance of notch is a reassuring sign for normal pregnancy. The persistence of notch and a high resistance waveform indicates the development of pregnancy-induced hypertension, PIH, and intrauterine growth restriction, IUGR. The persistence of diastolic notch after 24 weeks may be a good screening test for pregnancy-induced hypertension or preeclampsia. Uterine artery gives an idea of uteroplacental blood flow. The placenta, rather than the lungs, is the organ of gaseous exchange in the fetus. The umbilical arteries convey deoxygenated blood from the fetus to the placenta, and one umbilical vein returns oxygenated blood to the fetal inferior vena cava. Few clues to this, very important and very helpful. As the Doppler indices relate to systolic to diastolic components of flow, optimal angle of incidence is less important. Sampling of umbilical artery waveform can be performed at any point along the vessel. Thank you for watching. In this video, we discussed the schematic presentation of uterine artery and its branches in different layers of uterus and how they merge with the placental villi. In next video, we will discuss the normal and pathological blood flow patterns and their role in timely detecting preeclampsia. Subscribe to our channel for more exciting videos.